Hi guys, a very warm welcome to my channel Miss Medic. Just before I begin, a quick reminder, if you like this video, please don't forget to hit the like button, subscribe or drop a comment. I really would appreciate it. So today I'm going to be talking about retinal detachment, and to understand retinal detachment you need to have a basic understanding of the anatomy of the eyeball. And when we think of the eyeball, we think of it having three coats: an outer coat, the sclera, a middle coat, the choroid, and the innermost coat, the retina. And the retina actually has two distinct parts: the neurosensory retina, which is the innermost part of the retina, and the retinal pigmental epithelium. And the retinal pigmental epithelium is in direct contact with the choroid, and the neurosensory retina would be closer to the vitreous. So the retinal pigmental epithelium and the neuroretina are not that tightly attached, they're quite loosely attached. So they can come apart, and that is exactly what happens in retinal detachment. We have the separation of the neurosensory retina from the retinal pigmental epithelium, and then a potential space gathers, and in this potential space fluid builds up. This fluid, we would call it subretinal fluid. So you may ask, what's the big deal about retinal detachment? Well, retinal detachment is a medical emergency, so we have to act very fast. It's important to remember that the retina is an avascular structure, which means that it doesn't have its own blood supply. It typically gets its blood from the choroid. So retinal detachment can cause problems if there's no blood supply to the retina will become ischemic. So the prognosis of retinal detachment depends on whether the macula is involved and the speed of which we deal with retinal detachment. So as a medical student, I remember hearing a lot about the macula, and sometimes it could be difficult to grasp what the macula was. So the macula is basically an oval yellowish area at the posterior part of the retina, and it is responsible for giving us the most distinct vision. And it lies about 3 millimeters lateral to the optic nerve, or temporal to the optic nerve. You could use either term. And in the macula there's a small depression known as the fovea, and you see that here in this image. Now, who gets retinal detachments? Well, the incidence of retinal detachments are 1 in 10,000, but up to 6% of people have retinal breaks in their retina, which, when you think about it, is quite a lot of people in the general population. And what sort of people are more at risk of getting retinal detachments? Well, myopic patients, and these are patients who tend to have bigger eyes, longer axial length of the eye, and a thinner retina. So if you have a thin retina, you're more prone to tears, and if you are more prone to tears, you're more prone to retinal detachment. Also, patients who have had surgeries, perhaps a cataract extraction, retinal detachments could be a complication of a cataract extraction. And the most common type of retinal detachment is regimentogenous, which is a fancy term, and it comes from the Greek word break. And it is due to a tear within the retina, which becomes a full thickness tear, and this allows fluid from the vitreous to gain access to the retina and gathers in the subretinal space. There are other causes of retinal detachment, such as tractional and exudative, but these are less common. Tractional typically occurs in diabetic retinopathy, and in these types of detachments, there are no breaks in the retina, but fluid does build up within the subretinal space. So what are the symptoms of retinal detachment? Well, a patient would typically get flashes of light and flutters, and if you see a patient with these symptoms, you should consider a retinal detachment until proven otherwise. And retinal detachment also causes a sudden painless loss of vision. As retinal detachment advances, the patient may talk about a curtain coming down on their vision. What is the treatment? Well, the treatment for retinal detachment tends to be surgical. If the macula is still attached, this is a medical emergency, and the patient should have surgery within 24 hours. As we do not want to lose the macula, it's important it remains attached. If the macula is already detached, well, surgery can be carried out a bit later. The treatments include a scleral buckle, which is like a belt around the eyeball to keep everything tight and together, and it is used for simple retinal detachments and has a very high success rate. A piece of silicone sponge is placed around the outside of the eye and sewn in place. Other treatments include a vitrectomy, where the vitreous from the eye is removed. This may be used in more complex retinal detachments. So that's basically a very short summary of what a retinal detachment is and how it is treated. Of course, if you enjoyed this video, please hit the like button and watch my other videos about the retina and problems which can occur within it.